Walaikum salam, yes.
Okay, welcome to the neurosurgical case room. We are going to continue the session on CP angle anatomy. We have more or less covered the important CP angle, anatomical boundaries, and the contents and stuff. What we wanted to do yesterday, where we left off, was the vascular anatomy, particularly, and its relationship with the nerves. So please let me know first whether you guys want me to do a quick review of yesterday's anatomy, or can I proceed directly to the AICA?
Madam, a quick review, please.
Okay, okay. We will
A quick
do
review, please, and thank you.
okay. We will do a very quick review. Let me go back. So obviously we are not going to spend a lot of time doing all this skull base anatomy and stuff. Let's come back to the orientation. We did. Please keep yourself muted. Anybody who is not mute, please mute yourself so that we can continue uninterrupted. Okay, let's start with the boundaries. We know that CP angle is this narrow space, and we will see in the illustrations. The roof is made by the tentorium cerebelli. On the floor, we have the inner surface of the occipital bone. The anterolateral wall is obviously the petrous temporal bone, especially the petrous apex in that region. And the posterior medial wall is going to be formed by the brainstem in itself. Let's look at it very quickly. What you see here is the roof, this green structure, this is our tent. This is the tentorium cerebelli. This gray structure here is obviously the skull base, basio-occiput, and this is what makes the floor of the CP angle. Technically, the CP angle is, let me mark, it's only this narrow space somewhere around this region. It's not as big as I have drawn in my illustration. It's actually pretty small. And we did discuss yesterday what were the contents which were important here. There was inner ear around this region. There was posteriorly, we had the mastoid ear cells on this region. Here we had the petrous apex, and you can see the Meckel's cave, which is not visible. Obviously, you can see the ganglion here. So we know the basic structures. This blue structure was our anterolateral wall. What was the most important thing apart from the attachment of the tent and the other stuff? This vessel, which is this? Which venous structure is this?
Petrosal
Inferior
sinus.
That's right, this is superior petrosal sinus. Now, please remember the name because we are going to come back to this name later on in the session. This is the superior petrosal sinus. But pay special attention to the word sinus. It's not the vein. Apart from this, I think the boundaries are pretty easy to understand. This image was here because we wanted to have a surgical orientation. When we are looking at the patient, we know that the superior boundary of our surgical field is going to be this transverse sinus here, and obviously the junction of the transverse and the sigmoid sinus. Apart from this junction, the other thing which is going to be here is the stent, because tentorium cerebelli, the attachment of tentorium cerebelli to the posterior surface encloses the transverse sinus, right? So our superior boundary is obviously going to be tentorium once we go deep in, while our craniotomy boundaries are going to be centered around the transverse sinus and the sigmoid sinus. On this region here, we have the mastoid ear cells that we want to avoid so that the patient does not develop postoperative CSF rhinorrhea. Apart from that, we also would like to remember the orientation. Obviously, this is the cerebellar orientation, and the brain stem is also going to be oriented like this. And which particular part of the brain stem? Midbrain is above, medulla is below, So we are going to have pons here in this region. Hence the name Cerebellopontine Angle. This is actually a pretty narrow space, but you need to remember the orientation. So once we are entering this space as a surgeon, let me mark. Once we are entering this space, we have to retract the cerebellum and we have to go into this cistern, which is just a dural space filled with CSF. This cistern or the CPA angle cistern is where our interest lies. So I'm not going to draw because we will run short on time, but this is the exact region where we are interested in. This is the CP angle, and on this side you can see the boundaries and the structures which are going to be on the anterolateral wall. This is the posterior medial wall. If you're still not clear about today's anatomy and you are new to the session, then yesterday's recording has the complete detail of CP angle anatomy. Moving on, we have Roton's rules of three, and we are going to cover it very briefly since we spent a lot of time yesterday over it. There are three main complexes. We have the superior complex, we have the middle complex, and then we have the inferior complex. Let's go back. In each complex, there's going to be one artery, some nerves, one segment of brainstem, one cerebellar peduncle, one cerebellar surface, and a fissure, right? Superior cerebellar artery, cranial nerve 5, 4, and 3, they were a part of the superior complex. And obviously, the most superior portion of the brainstem is going to be midbrain. So that is a part of superior complex. Superior cerebellar peduncle, easy to remember, and the superior surface of cerebellum, which is the tentorial surface, right? And then the cerebello-mesencephalic fissure. Mesencephalic means that this is concerned with the midbrain. It's easy to remember if you know you end up confusing the structures. I am audible, right?
Yes, ma'am, you are
you're
audible. Thank you.
Okay. So the only thing that we are interested in while doing any surgery which approaches the CP angle, superior complex comes into our field when we are operating usually for trigeminal nerve pathologies, especially trigeminal neuralgia, and you are doing microvascular decompression. Then you're going to concern yourself with the SCA. Otherwise, since the intention with which we started doing the CP angle anatomy was doing the retrosigmoid approach, for us, the superior complex is not of much interest. Middle complex is what we are most interested in. AICA, the 6th cranial nerve, 7th cranial nerve, and 8th cranial nerve. Brainstem segment is as visible from the name, since it's the middle complex, the middle of the brainstem, which is pons, the middle cerebral peduncle, petrosal surface, which is the lateral surface. Let's go back. This region here is the petrosal surface of the cerebellum, this lateral surface, and this portion. So this portion here is the lateral or the petrosal surface. That is a part of the middle complex. It's understandable because this is the surgical corridor we are going to use. Apart from that, we have the cerebellopontine fissure because we are working with the cerebellum and the pons. Easy to understand, right? What were two important things that we established yesterday? I think we did. I think we discussed one and we left out the other. We were discussing the orientation of the facial
Yeah.
nerve and the vestibulocochlear nerve. So how are they arranged?
Anterior and posterior.
That's right. Facial nerve is anterior and vestibulocochlear nerve is posterior. Always remember this. Facial nerve is anterior. As in, when I'm talking to somebody, I'm facing them, my facial nerve is anterior and it's facing the other person. Vestibulocochlear nerve is behind the facial nerve, even though they go together. Why is this important? We discussed that yesterday as well. It is important because assuming this green structure is the vestibulocochlear nerve, and the vestibular component starts developing a schwannoma. What is it going to do? It's going to push the facial nerve anteriorly. Let me draw the sandwich. And the other thing that is going to happen is, this is the cochlear segment of the vestibular cochlear nerve that is going to be pushed inferiorly. If you can't remember the cochlear segment, that's perfectly fine, but you need to know the orientation of the facial nerve, because as surgeon, there will be times when even after debulking the lesion completely, you will not be able to see the facial nerve because it will be completely thinned out, stretched, and splayed across the anterior portion of the tumor capsule. Am I making sense?
Yes, ma'am.
Okay, so facial nerve gets draped anteriorly. Now, always remember this when you are approaching the patient, because retrosigmoid is a posterior, in fact, a posterior lateral approach. You are approaching from the posterior surface, right? You're using a posterior corridor. Please keep yourself muted. We have a lot of people who are unmuted for some reason. Let me see. Okay. So what happens is, because retrosigmoid is a posterior corridor, we are approaching this structure and this complex from behind. The first nerve that we are going to encounter is going to be the eighth nerve, or the vestibulocochlear nerve. We will not see the facial nerve in the first instance. And this is the reason retrosigmoid approach is not famous for facial nerve preservation. You all know that, right? This approach is not superior to the other two options, the labyrinthine and the middle fossa, in terms of facial nerve preservation. Because it's a posterior approach, you encounter vestibulocochlear nerve first, hence the tumor first. The facial nerve is draped anteriorly. You don't see it until and unless you do a very careful debulking and arachnoidal peeling of the tumor capsule away from the facial nerve. Are we all on the same page?
Yes, ma'am.
Yes.
Okay.
Yes, ma'am.
Yes, ma'am.
Apart from this, I don't think we have anything important to do. Okay. So the other thing that we discussed briefly was AICA. And we know that AICA can have variable anatomy in 30 to 40% of the subjects. Sometimes it branches early, sometimes there are two trunks. We are going to discuss that. And sometimes it gives labyrinthine artery way early on during its path. So any perforator that you encounter during the vestibular schwannoma surgery, you have to be very careful in terms of coagulating. Bipolar is your best friend, but bipolar is also the biggest enemy. Probably anybody who has been listening to me for a while knows that I say this. Apart from the first two complexes, we have the third complex, which is the inferior complex. We have pica and the lower four cranial nerves. Three of them go together. Hypoglossal goes separately via the hypoglossal canal, but they more or less travel the same region. Brainstem segment is obviously inferiorly. We have medulla, inferior cerebellopeduncle, suboccipital surface, because this is the inferior complex, and cerebellomedullary fissure. Even if you don't remember all of this, there are two things that you should remember: the artery of any complex and the cranial nerves of any complex. If you can remember that, you're good to go. So this is an illustration that we covered yesterday. Let's not stay here. Okay. Even though we have covered this yesterday, I'll just go briefly over it because it emphasizes what I said previously. You can see the retrosigmoid approach here. This is after the dural exposure. The dural flap has been raised. The cistern of the CPA angle has been opened. What do I mean by opening the cistern? Any empty space, let me draw. Any empty space, for example, this is the petrous part. This is the occipital bone, and then we have the cerebellum here. Please excuse my very poor illustration, but any empty space inside the brain gets filled with CSF and gets lined by arachnoid. So this becomes a cistern because it's big enough to be called a cistern. What we say as CPA angle, in actual anatomy or actual subjects, it is a CPA angle cistern because there are arachnoidal layers and there is CSF within it, and all these neurovascular structures flow inside the cistern. So once we open the dura, we open the arachnoid and we drain the CSF. So the CPA angle cistern is now completely open. And we need to retract the cerebellum towards the midline very gently. Dynamic retraction is your best friend. And then you go in to see cranial nerve 7 and 8. Let me clear this. And if you see, they have not mentioned it clearly, but this is the vestibulocochlear nerve and this is the facial nerve. Anytime you see an anatomy and a diagram of anatomy or a surgical picture of retrosigmoid approach, the exposure is from behind. Be very sure that the first nerve you are seeing, which is this,